Can't help it.
Oh, yeah.
I left earlier.
Roll up? Take the boat?
Oh, I wish.
Yeah.
It'll be a fun day down there.
Yeah, it's supposed to be.
Okay. In fact, to have all your attention, it's a great pleasure to welcome you to our third annual Prostate Cancer Symposium that's supported by the Institute for Prostate Cancer Research. So this is really a report back to the community to inform the public about the advances made in the prevention and treatment of prostate cancer, the most commonly diagnosed cancer in men and the second leading cause of cancer-related death. So we within the Seattle community believe that the quickest route to eliminating or preventing prostate cancer is really through developing strong partnerships between scientists in the laboratory, the clinicians and the physicians, and probably most importantly the public, the patients, the families of those individuals with prostate cancer. We really need for all of you to be active participants in research and very vocal supporters of research. So the Institute for Prostate Cancer Research is a collaboration between the University of Washington and the Fred Hutchinson Cancer Research Center that's really designed to rapidly identify and advance scientific knowledge and move it into daily clinical practice where it can impact and effectively be used to treat and prevent prostate cancer. Dr. Paul Lang is the director of the IPCR, and you'll be hearing from him later today. So the intent and the objective of today's symposium, there are really four major areas. First is to provide information to you concerning the current state of research in prevention, screening, and treatment for prostate cancer. We want to highlight some exciting new developments in research that's happening right here in Seattle. We want this to be an interactive dialogue, so this is really a forum for discussing questions and trying to clarify issues related to prostate cancer. So as you'll see as we go forward, there's time for question and answer and dialogue. And then we really want to emphasize again this importance of the community participation and partnerships to prevent and cure prostate cancer. I do want to dedicate this year's symposium to Mr. Thomas Wright, who was a very substantial supporter of the IPCR. So Mr. Wright was really an innovator in the field of education, primarily childhood education, and developing textbook teaching approaches for young people. He was treated for prostate cancer and actually cured of his prostate cancer at the University of Washington, but last month passed away from other causes. So we want to dedicate this educational symposium really in his memory. So the program for today is really as follows. You probably have it in your handout. This is the big picture view. We've divided the symposium into three broad areas. One involving cancer risk and prevention, the second in managing localized prostate cancer, and then the third part in thinking about more advanced disease. In between each of these sessions, we have a break for biology, which is coffee, as well as the bathrooms that you'll see on either end of the building here. And then we have a lunch that I'll talk about in a moment. So drilling down a little bit more, this is the planned schedule for the different speakers. We're going to hold questions at each session to a Q&A period after 4 or 5 talks, and the people that gave the talks will be down here at the front of the room with microphones, and so we'll open it up at that point to questions back and forth. I think you've also been given cards. If you don't feel like you want to stand up and ask a question, you can also write that question on a card and pass it to Nola, who's in the back of the room there. So, and she'll hand them to me, and I'll MC that Q&A period. And then at the end of each of those, you can see that there's a break. So if your specific question to someone that spoke wasn't addressed, you can go grab them during the break and ask them a more one-on-one question. And then here's the plan for the afternoon that focuses more on advanced prostate cancer. So some special thanks to Nola Klempas, who is our IPCR Act Smart manager, who helped organize this symposium, along with Jesse Kasten, the development staff at the University of Washington and Fred Hutchinson Cancer Center, Mike Rubin, and Colin Ware. And their names are actually written in your program. If you want any future information over time, please feel free to contact them. I want to thank the prostate cancer support groups for all their efforts in our region, and several of them will have tables at lunch that you can talk to. And then we've received some special support from Bayer Healthcare that has provided some funds for this meeting today. So a few final details. I mentioned at lunch there'll be tables from support groups and sponsors. These talks will be recorded and they'll be posted on YouTube, and we'll have a link to that on the website where you registered, so you'll be able to watch them or send them to other people as you wish. I mentioned the question cards. Please use those. This is the most I think useful probably for you and for us if you are very vocal with your questions, or tell us over time how you'd want to see this improved or topics covered in subsequent years, because we do plan on doing this at least once a year and possibly more often, depending on interest and questions. So with that, that's really my introduction. We'll get started with session one. We're right on time, and our first speaker is Dr. Marian Neuhouser, who's an affiliate professor in epidemiology at the University of Washington and a member of our Fred Hutchinson's Cancer Research Center, and she'll be talking about diet and lifestyle and what you can do. Marian?
Thank you, Pete, and it's wonderful to see such a great audience this morning. Thank you all for joining us on a beautiful Saturday and giving up several hours of your day to join us. Hopefully we'll make it worth your while. So a prostate cancer diagnosis, as all of you know and your family members know, can be quite unsettling. You likely have a lot of questions, you had to make treatment decisions, and you're not alone. As Dr. Nelson said, prostate cancer is the most commonly diagnosed cancer among men in the United States. And for all cancers, 1 in every 25 Americans is a cancer survivor. So you're really not alone. There's a lot of cancer survivors out there who have many of the same questions that you do. For many people, prostate cancer diagnosis can be a time to think. It can be kind of a wake-up call for, is this a time you want to change some of your lifestyle habits? And it's a good time to kind of reassess some of the things that you do on a daily basis. The good news is that there's increasing scientific data to suggest that your lifestyle habits may be very important for your long-term health and prognosis. In 2012, there was a comprehensive report that detailed various cancers, including prostate cancer, and the importance of a healthy lifestyle. And I had the honor and privilege of being part of the group that wrote this report. And we came up with this. For cancer survivors, healthy weight management, a healthful diet, and a physically active lifestyle aimed at preventing recurrent, second primary cancers, and other chronic diseases should be a priority. So really there are 3 pillars of a healthy lifestyle: body weight, physical activity, and diet. In the next few minutes I'll detail all 3 of these healthy pillars. So why are these important? This slide here shows how food, nutrition, body weight, and physical activity really impact all parts of the cancer process, from DNA repair, which you see up here at the top, cell proliferation. Nutrition, physical activity, and body weight have to do with hormones, because the more body fat a man has, the more sex hormones he'll produce. Cell differentiation. Overweight people tend to have more localized and general inflammation. That can be related to cancer development and prognosis. Apoptosis, or programmed cell death, can be influenced by these lifestyle factors, and also the cell cycle. So all phases of the cancer process are influenced by what you eat, how active you are, and your body weight. This is an interesting study that was published quite recently. It wasn't done by scientists here at the Hutch, but we know several of these, and we have interacted with many of these investigators. And they found that for men who had a prostatectomy, if they gained about 10 pounds after their prostatectomy in the subsequent years, then their risk of recurrence was about twofold higher compared to men who didn't gain any weight after their prostatectomy. So just a reminder that weight management is very important in the treatment and subsequent era. This was a subsequent study done called a meta-analysis. And in a meta-analysis, the investigators look at a lot of published data and more or less pool all the data together to try to figure out what's the overall picture, thinking about the totality of data with regards to certain risk factors and outcomes. So we see here a number of studies that have examined weight and weight change after a prostate cancer diagnosis. And what this vertical bar indicates is no risk. The lines to the right of the vertical bar indicate an increased risk associated with weight gain after prostate cancer treatment, and the one bar to the right indicates a lowered risk for weight gain after prostate cancer treatment. So you can see that the preponderance of evidence suggests that there's an increased risk of poor prognosis associated with weight gain after a prostate cancer diagnosis. And what we call the overall summary relative risk suggests that there's about a 20% chance, or 20% probability of poor outcome for about a 10 to 20 pound weight gain after prostate cancer diagnosis. So that's a meta-analysis. And so this tells us that the evidence is pretty convincing and consistent. We don't like to use just one study to draw our inferences about clinical treatment. We'd like to have the totality of evidence, and that's what this suggests. So now let's move on to the next pillar of a healthy lifestyle, and that's physical activity. So how much physical activity should you get to stay healthy? And what are we talking about? The current recommendations for cancer survivors is that you should get about 150 minutes a week. So it really isn't very much. That's about 20 to 30 minutes a day of moderate intensity activity. So you might be asking, how do I know if I'm getting moderate intensity activity? Moderate activity is where you can talk, but you can't sing while you're doing that. So if you're on a walk, if you can sing while you're walking, walk faster. You can talk, but just don't sing. Or if you're doing vigorous activities such as riding a bike or some other type of vigorous activity, that's judged by if you can only say a few words without stopping to catch your breath. That's vigorous. So if you do vigorous activity, you can do less. If you do moderate activity, remember you can talk but you can't sing. And does the type of physical activity matter? Not really. Any activity is better than none, but there are some intriguing data about resistance training and whether or not that would specifically help prostate cancer patients. And we really need more research in this area. So something I'm interested in pursuing in the future is whether or not resistance training would be particularly important, especially for the bone health. I think we're going to have questions at the end, sir.
What is resistance training?
Oh, good question. Resistance training is things like weight training, where you're trying to build up your muscle mass. And that would be contrasted with aerobic training, which is walking, cycling, anything where you're short of breath. That would be called aerobic activity. So this is a study that was a randomized trial where men were undergoing radiation treatment for their prostate cancer, and they were randomized to either resistance training, such as weight training, or aerobic exercise. And what they found was that the men who underwent the aerobic and resistance training had reduced fatigue. The physical activity overall also improved their body composition, so it improved their muscle mass and bone mass, it improved their weight, and it improved their quality of life. So these are pretty salient results. So I'd like to kind of challenge or encourage everyone that if you're not physically active, it's not too late to start. You don't need to go to a gym, you don't have to have fancy equipment. Walking is great. It's just a great activity. And you can start today. Today is going to be a beautiful spring day, and even tomorrow. And we're going to end this afternoon at about 2:30. We have a beautiful park, Lake Union Park, that you can walk to, take a walk around the park, and then take off for the day. And that'll take about half an hour, and then you get your physical activity in for the day. It's going to be beautiful this afternoon, and tomorrow. So take advantage of it. Get out and walk. 20 to 30 minutes a day really isn't very much. When you think about the minutes of the day that you spend doing other things, 20 to 30 minutes a day is not very much. You know, I can easily waste 20 or 30 minutes, I don't know, whittling away the time, doing something. 20 to 30 minutes a day is not much. Start with 10 minutes and then add a little bit each day. It does need to be at least 10 minutes. Physical activity experts suggest that if it's less than 10 minutes, you don't really get your heart rate going and your blood going, so it needs to be in what we call at least 10-minute bouts. So walking from here to your car when we're done, that doesn't count because it needs to be at least 10 minutes. So start with that and then work up. The third pillar of a healthy lifestyle is diet. And this is not a new concept, for after all, Hippocrates, who's the father of medicine, over 2,000 years ago, he said, "Let food be thy medicine, and medicine be thy food." So this concept has been around for a long time. And in a nutshell, since our presentations are rather brief this morning, I'll simply say eat more of these. Here you see a lot of vegetables, beans, whole grains, lean meats. Eat more of those. Try to fill up your plate with as much color as possible. And limit foods that are high in sodium, added sugars, and refined grains. Doesn't mean eat no grains, just limit your amounts of white bread, white rice, things like that. But do include grains. Grains get kind of a bad rap these days, not really based on any science. Also think about portion size. We really have these days what's called a portion distortion. And some of you probably remember the phrase, supersize me, that was around a few years ago when there was a popular movie about it. Well, that still exists. About 20 years ago, this was a cup of coffee. And if you put a little bit of sugar in it, and even if you put in cream and milk, it was only about 45 calories. Today, this is just one example. If you order a mocha where the milk is and the chocolate are about 3/4 of it, maybe to more than that, and then the syrup, that's 350 calories. So the difference is about 305 calories. So it doesn't mean never drink a mocha, but think about the portion size and think about it before you decide to order this instead of that. Same with muffins. 20 years ago, this was a muffin size. You know, the size in the muffin tins that you might have in your home to bake muffins? That was a muffin size, 210 calories. Today, if you go to Starbucks or any bakery, this is a muffin. They're huge. They're about 500 calories. And if you're trying to lose weight, 500 calories is going to be more than 25% of the calories you need for the whole day. If you're trying to maintain weight, it's still going to be about 25% of the calories. So just think about the portion size when you're choosing things. Maintain a healthy weight is a balancing act between calories in and calories out. So if you do choose that muffin, then think about what kind of activity you'll need to do to balance it out. So if you walk the dog for an hour and 20 minutes, you'll burn about 400 calories. Some people find structured programs helpful, but it's not necessary. Some words of caution that I would give you is that if it sounds too good to be true, it probably is. So there are some popular books, programs, dietary supplements that will promise that you will lose weight or be healthy without ever having to diet, watch what you eat, or exercise. Don't believe those. They're too good to be true. Avoid diet regimens that are extremely restrictive or omit entire food groups, such as those that tell you to avoid all grains, including whole grains. Many of us in the room that you'll hear from today are very interested in doing research in this area on lifestyle factors that can improve the health of prostate cancer patients. And we have a study that we hope to conduct called the Prostate Cancer Active Lifestyle Study. The principal investigator will be Dr. Wright, who you'll hear from this morning, and other co-investigators include myself, Dr. Lynn, who you'll hear from later, Dr. Stanford, who you'll hear from this morning, and several others. And our overall goal is to test an intervention of weight loss, diet, and physical activity among overweight and obese men who are on active surveillance. And I'll leave you with one final note, and this underscores everything that we do here, and that is that credible research is very critical to inform patient recommendations and patient care. So I'll look forward to hearing your questions when we have our question and answer time. Thank you.
There are always 100 questions for Marian, so I'm sure you'll have them. So our next speaker is Dr. Janet Stanford, who's co-head of the prostate cancer program here at our NCI Comprehensive Cancer Center, and she'll be talking about inherited risk for prostate cancer. Janet?
Thank you, Pete, and just to echo Marian's comments about welcome on a beautiful Saturday morning to allow us an opportunity to share some of our work with you and hopefully inform you in this talk about genetic background and why that's important in terms of your risk of prostate cancer. So we know that genetic and environmental factors are important in causing cancer, and on this slide you can see that over 40% of the incidence of prostate cancer has been attributed to underlying genetic factors, and these are factors that you're born with or inherited with, and it's the DNA in almost all of the cells in your body. And what I'm going to be sharing with you today is going to be referencing relative risk, and so I think it's important to review this concept with you. When we talk about a relative risk, what we're doing is really comparing or creating, computing a ratio, and this is the risk for our examples today of prostate cancer in an exposed group, and this would be perhaps men who carry a particular genetic variant compared or relative to an unexposed group, and this would be the group of men who don't carry that genetic variant. And so we want to look at prostate cancer incidence in those two groups and see if they're different. And when we calculate our relative risk, if it equals to 1, what this tells us is that there's absolutely no difference, that having that genetic variant does not change the incidence of prostate cancer. However, some of the results I'm going to show you today are going to have relative risks that are above 1, and in this case it indicates that that genetic variant increases the risk of developing prostate cancer. So many of you know that family history is a strong risk factor for developing prostate cancer, and for men who have no first-degree family history of the disease, and this would be prostate cancer in a father, a brother, or a son, comparing those men to men who do have a first-degree relative who's been diagnosed with the disease have about a 2.5-fold increase in their risk of developing prostate cancer. And if their relative was younger at their age at diagnosis, or if there are multiple relatives within the family who have been diagnosed with prostate cancer, that risk is even higher, as you see, up to 5-fold higher compared to men who have no such family history. So this slide is a little bit complicated, but I think it presents an important concept when we're thinking about our background genetic risk for disease and how that is associated with the risk of developing a number of diseases. And the concept is that when there are common genetic variants, and we'll call these risk alleles, and these are just variations in the in your normal DNA. If you have a common risk allele, and these are above 10% in the general population, those tend to be associated with very low or modest increases in the relative risk. However, if there are rare low-frequency alleles or mutations in genes, these tend to have a much stronger effect on your risk of developing disease. And so in terms of prostate cancer, keeping this concept in mind, where are we today in terms of our understanding genetic background in relationship to risk of prostate cancer? So I mentioned there are common low risk, and by common I mean the risk allele is carried by 10% or more of the general population. We have knowledge that there are currently 100 validated or confirmed in multiple studies of these common genetic variants that contribute to risk of prostate cancer, but they contribute in a very modest way, and on average, these variants increase your risk of developing prostate cancer by about 10% to 30%, so very modest effects. However, if you remember on the other slide, variants that are less frequent in the population, and we think of these as less than 1%, less than 2%, if you have a genetic variant or a mutation in these genes, it turns out that they contribute much more significantly to increasing risk of prostate cancer, and most of these are relative risks that are going to be above 2. And so I want to show you some examples of that relative to some of our work here at the Cancer Center on 3 of these genes. And in order to find these more deleterious, if you will, less common and rare genetic variants that contribute to risk of prostate cancer, one of the best ways to find those is to study prostate cancer families. And so we started a family study called Progress back in 1995, and we're following about 2,300 members of over 300 prostate cancer families. And these families have a pattern of what we call hereditary prostate cancer because they're multiple generations. 3 or more men in the family have been diagnosed with prostate cancer, and many of them are diagnosed at a younger age. So when I refer to the family study Progress, this is the population that we've been studying. And we were interested in BRCA2 mutations. This is a well-known gene that carries mutations that are associated with breast cancer. There was some indication from studies of breast cancer families that the men in those families had a higher risk of developing prostate cancer. So we wanted to look in the prostate cancer families and see, indeed, do BRCA2 mutations carry a higher risk? And so we looked at 194 Progress families, 266 members of those families, and we didn't find any mutations in BRCA2. And this is consistent with other studies that have taken hereditary prostate cancer families and looked for increased risk related to BRCA2, which is different from if you take the breast cancer families and look at risk. And so we don't really understand this initially, except that it looks like BRCA2 is really not necessarily so important in hereditary prostate cancer families. What it seems to be telling us is that it's more strongly associated with early onset prostate cancer, young age at diagnosis. And so we have a large set of prostate cancer patients and age-matched men without prostate cancer from King County, Washington, that have contributed to our research studies. And so we went and tested about 300 of these men for BRCA2 mutations, and all of these men were diagnosed with prostate cancer at age 55 or younger. And we did indeed find that 2 of these men carried deleterious mutations in BRCA2. And this, as I mentioned, these rare variants are at low frequency, so less than 1% of those early onset prostate cancer patients carried the mutation. But if you had the mutation, your relative risk of developing prostate cancer is increased almost 8-fold. Second example I want to talk about is a gene called HOXB13, which many of you may have read about. This is a rare mutation. It's a single base pair or spelling change in the DNA code. And when we looked in the Progress families, we looked at the specific mutation, and even though it's rare, it was associated with over a 2-fold increased risk of the disease. And then we're part of a big international consortium of about 15 groups that have a large collection, and in this example, over 2,400 hereditary prostate cancer families were tested for this mutation. And again, the relative risk was consistently above 2. Well, so clearly this mutation is important in hereditary prostate cancer and is found in about 5% of hereditary prostate cancer families, but we're also interested in knowing if this mutation plays any role in patients who are not selected based on having such a strong family history. And so we can do this because of the participation of men from King County in our research studies. And what we found was, as you can see, in men without prostate cancer, very rare, 0.4% of those men from King County carried this mutation. In those prostate cancer patients, about 1.3% of them tested positive for this particular mutation, associated with a relative risk of above 3. So again, an important rare variant or mutation that contributes significantly to development of prostate cancer. The last example I want to share with you was a genetic mutation or variant that we discovered based on the Progress families, and we published this last year. And it's a gene called BTNL2, and I just want to share with you this bottom family tree, if you will. And so here there are 4 brothers in this generation. 3 out of the 4 brothers have prostate cancer, and all 3 of them carried this mutation. Their brother that's unaffected was tested, and he does not have the mutation. We also tested their sister, and she carries the mutation and passed it on to her 3 sons, and all 3 of those sons have early onset prostate cancer. So pretty impressive pedigree. And when we looked in our larger set of families, 270 additional families with hereditary prostate cancer from our own Progress study, we found that the relative risk associated with carrying the most frequent of these mutations, which was found in about 1.5% of the prostate cancer patients in these high-risk families, was associated with a 15-fold increased risk of prostate cancer. So rare, but very important. Again, we looked in the King County population, and what we found was that the most frequent of these, carried by slightly under 1% of the general population, but carried by slightly over 2% of prostate cancer patients, was associated with a 2.7-fold significant increase in risk of prostate cancer. So just to summarize, based on what I've shown you today, your inherited background, the DNA that you're born with, is very important in affecting your risk of developing prostate cancer. Both rare as well as less frequent genetic variants are associated with the disease. I think at this point we've pretty much found all of these common genetic variants that contribute to a very low to modest risk of prostate cancer. But what we haven't found, and the piece of the puzzle that's still missing, is the discovery of more of these genes that have rare and less frequent mutations. And because of the advent and advances in next generation sequencing technology, we're now actually involved in 2 very large sequencing studies that we think are going to find more of these rare, high-risk genetic mutations that contribute to the disease. And then finally, the last question is, how can we use this information about your genetic background to try and personalize a protocol for screening, prevention of prostate cancer, and even targeting therapeutics? Thank you.